So thank you all very much for being here with us tonight. And I would have given Dr. Desperito like another 10 minutes because that was really very good. And I don't know about you guys, but the opportunity to look at those images with a radiologist is extremely important so that some of the concepts that you hear about density and so on are not just abstract terms, but you've really had a chance to look at mammograms and recognize what a challenge it is for the breast radiologists and how important it is to do your mammogram at a facility where you've got well-trained experts in reading mammography to interpret your images. So that's another request. If you're going to have a mammogram, do it in a place where you're going to get the best possible performance technically of the films and the best reading from somebody like Dr. Desperito. So I'm kind of going to bring it home tonight. Okay, good. I'm going to finish the presentations this evening in this seminar, and I am going to include in my presentation some information that Dr. Kathy Ann Joseph would have presented had she been here this evening. So I'm going to do my talk, and I'm going to stand in her stead a little bit. And one of the things that I'm going to incorporate into my talk for Dr. Joseph is a little bit of additional information about the complexion of breast cancer in women of color. And we're going to put a little bit of additional information out there that is relevant to women of color in the topic of breast cancer risk and so forth. So let's start this off with some basic statistical information from a big national database in America that shows that for women who have cancer, the long-term survivals are going up, and the death rate from breast cancer in particular, as Dr. Desperito mentions, has been reduced substantially over time. So this is a graph of the 5-year survival based on year of diagnosis, going from 1975 to 2003 for women. And you can see that we have made tremendous strides in reducing the death rate from breast cancer in America. Screening and early detection are a big part of this, and we recognize that better treatment modalities contributes as well. Now, I'm going to review a little bit of this information about risk. I'm going to spin it a little differently for you. Obviously, all adult women are at some risk to develop breast cancer. That's what we call baseline population risk. And not only is gender a risk factor, but so is age. Your risk for breast cancer goes up as you age. That's true for everyone. And this table from the American Cancer Society looks at the risk of breast cancer by decade of age. Before age 40, it's 1 in 207, and that increases, particularly taking a big blip upward at around the time of menopause. In the 60s, it's 1 in 29. In the 70s, 1 in 15. And from birth to death, about 12% lifetime risk for breast cancer in American women, but you can see that younger women are at much less risk. It's one of the reasons why we don't screen them regularly. Now, this is a depiction about the way that breast cancer incidence looks in America for African American women as compared with Caucasian women. And I've circled in blue the information about the risk for breast cancer. So if you take a look at those bar graphs, the dark lines are the African American women as versus the Caucasian women, you can see that African American women, although their overall risk for breast cancer is a little bit lower than Caucasian women, their risk for being diagnosed with later stage cancers is actually higher, probably as a result of access to screening. And in addition, when you look at death rates, the death rate from breast cancer in African American women is substantially higher than the death rate from breast cancer in Caucasian women. And we're going to get to some of the possible reasons why that's true. This is similar data for women of Hispanic origin. And here it's a kind of an interesting perspective once again, a little bit more likely to be diagnosed with later stage disease versus earlier stage disease. And here the 5-year cancer-specific survival is a little bit lower in Hispanic women when compared with Caucasian women, but the differential is not that great. It's about 6% differential. Now, as it turns out, in African American and Hispanic women in the U.S., breast cancer is actually their most commonly diagnosed type of cancer that they have. But as I said, the pictures are a little bit different. So overall, African American women have a slightly lower risk of breast cancer when compared with Caucasian women, but in women under 45, in younger women, the incidence of breast cancer is actually higher in African American women. And in that population, they are more likely to have breast cancers that have poor prognostic features, that are more aggressive disease and associated with worse outcome. In particular, the kind of breast cancer that we call triple negative, which is a type of breast cancer that is not sensitive to two of our important treatment modalities, hormonal therapies and targeted therapies, and where chemotherapy is the only effective treatment. That probably is a big contributor to the relative increased death rate among African American women who have breast cancer. Now, interestingly, in Hispanic women, there's actually a lower overall rate of breast cancer when compared to non-Hispanic Caucasian women. Why is it? Some of this has to do with probably different reproductive patterns. We heard a lot from Dr. Smith about estrogen and about childbearing and breastfeeding and so on. So Hispanic women may get some protection from their typical patterns of reproductive life. They also may use less HRT, but some of that difference may also be due to lack of detection because of less access and uptake for screening. Now, just a quick review. All the other speakers have kind of hit on this. Just a listing of the common and important risk factors for breast cancer. So having had one breast cancer puts you at risk for getting another one. Family history of breast cancer and ovarian cancer are very important to know about. Having an early first period, a late menopause, or taking additional estrogen into the system after menopause is important. Having no children or a first child later in life after 30 increases the risk. A history of biopsies that show abnormal cells or atypical cells in the breast increases the risk. Radiation therapy, like women who survived Hodgkin's disease, also increases the risk. And as Dr. Desperito just very cogently put together for us, there is information that suggests that having the type of breasts that are characterized as dense on mammography may by itself not just impact on detection rates, but actually may increase the risk for developing breast cancer, although we need to get a little more information on that before we make conclusions. Now, as it turns out, though, everybody's listed these risk factors a few times this evening. These risk factors are not all created equal, and some of them are more important than others. For instance, women who have those atypical cells that we spoke about over here have about a 5 times increase in their risk for breast cancer. But if you have those atypical cells in your breast that are found on a biopsy, and you also have family history, the risk somehow synergistically goes up, and the risk is then at least 10 times that of the general population. So these risk factors are not all equal, and they interact with each other in complex manner. And women and people are messy and frequently have risk that comes from a lot of different directions that we have to combine to get an overall risk picture. And certainly, as Dr. Smith pointed out, there are unique families around where there's breast cancer in every generation, young women affected, lots of bilateral cancer, even ovarian cancer as well. Now, these are really unique situations. It's not that common. This represents about 10% of the population with breast cancer, but in these unique family situations, they may in fact represent an inherited genetic tendency to breast cancer. People in that genetic group are the highest risk group that we know about. In order to try to combine these risk factors in a way that gives people real information about their individual risk, as Dr. Desperito just talked about a couple of minutes ago, there are some mathematical models that have been developed that a woman can input all of her different risk factors in her age and ethnicity and so on, and then come up with a predicted risk for herself for developing breast cancer. And the most common of these models that's used is called the Gail model. And it includes all of these different factors that you see up on the screen. That's what Dr. Desperito's website that she showed you was based on, the Gail model. This is the most commonly used model around today, and it's very widely available. But a model is just a crude approximation of risk. And the Gail model has some very specific limitations. It doesn't give an accurate risk prediction for people with certain conditions, like LCIS that Dr. Smith spoke about, or women who've actually themselves already had a history of breast cancer. It also doesn't incorporate family members who have had breast cancer who come from the paternal side, because it only includes first-degree relatives, parents, siblings, children. If an individual has breast cancer coming from the father's side, the father is unlikely to be affected, but other of his relatives may be affected. That doesn't feature into the Gail model. The Gail model ignores all that because these are second-degree relatives and further on. And another big point about the Gail model is that it seems to be very clear that the Gail model doesn't work very well for non-Caucasian populations. So the Gail model gives a crude approximation, but it doesn't give us very specific and accurate information. And another example of a limitation of the Gail model is that because it only asks how many first-degree relatives have had breast cancer and not anything further about those cases, if a woman's mother had breast cancer at 90 or at 30, it looks the same in the Gail model. So that's not terribly accurate. Genetic testing for people who are found to have the breast cancer genes is actually a really, really accurate risk assessment tool. For women who have the BRCA genes, BRCA1 and BRCA2, their lifetime risk for breast cancer, 50 to 85%. That's the highest risk group that we can ever identify, and that gives a tremendous amount of clarity for women who are in that group. And as we said, a minority of women with breast cancer are in that group. Here are some of the things that lead you to believe that someone may have one of those genes. If they're positive, the genetic testing gives tremendous information. If they're negative, not quite as much precise information. Now, why do we care? Why is it important to give somebody an accurate understanding of their potential risk for breast cancer? I think there are a few reasons. First of all, we like to give people objective statistical information. Saying you're at high risk without qualifying it is not terribly meaningful, and then that makes it difficult to use that information in a way that's constructive and informative. We need to develop age-specific and risk-specific screening approaches, as Dr. Desperito said. Not everybody should be screened for breast cancer in the same way, and heaven knows if we were ever able to identify a cohort of women at low risk for breast cancer, it would be a pleasure to say to them, you really don't need to get mammograms every year. You can get them every other year or maybe even every third year. We're not quite there yet. It's also important when we talk about our risk reduction strategies to make sure that they're being offered to the right group of people and that we can figure out how well they work by comparing similar risk groups with any intervention. And we'd like to really know how well some of these interventions work. So, if going through the exercise of risk assessment, an individual is identified as at a risk for breast cancer that's increased over other women of her age, what are the strategies that we can offer her to deal with that risk? So I think that there are really four topics: surveillance, prophylactic surgery, chemoprevention, and lifestyle modifications. We're going to go through them all. Surveillance programs are all about early detection. And early detection of breast cancer has two specific benefits to the patient. I know you've heard this before, but you can't ever say it enough. Number one, early detection gives you a better prognosis, and that is absolutely clear. Number two, and this is very specific with breast cancer, the treatment that's required for early stage breast cancer is less harsh, less obnoxious, and may interfere less with typical daily life. And you all know what I'm talking about. The ability to have breast-conserving surgery, the ability to say that someone does not need something like chemotherapy, that's a big deal. And that's a huge benefit of early detection. Now, there are elements of surveillance. There are three elements also of the surveillance programs: breast self-exam, breast exam by a professional, and breast imaging. Breast self-exam is something that's been talked about a lot in the media and in the professional and the lay media, and it's very clear that breast self-exam is not as effective as the imaging tests that we have in terms of finding breast cancer when it's really, really early. However, that doesn't mean we shouldn't be aware and we shouldn't look. And the same way that we've been really great in the medical profession at counseling people that they need to look at skin lesions, and if a mole gets bigger or changes color or bleeds or whatever, you should bring it to medical attention, women should also be aware that if they see an obvious change in their breasts, that should be brought to medical attention. So it's about common sense and self-knowledge. At this point, in terms of imaging of the breast, mammography is the only imaging modality that has been shown, when used regularly in mature women, to reduce the death rate from breast cancer. That's the gold standard. How you use mammography depends a little bit on risk. The age where someone should begin doing regular mammography may be modified from the general guidelines if there's a significant family history for breast cancer. That makes sense. If a woman's mother had breast cancer at 38, she should probably be screened younger than the typical recommendation between 35 and 40. Now, there's been a lot of controversy about this. 2 years ago, there was a big dust-up in the media from the U.S. Preventive Services Task Force when they said, maybe there's not really good evidence that we need to do mammograms every single year, and maybe we shouldn't be doing them till 50, and maybe we should stop at 74 or 75. And people lined up on all sides of this argument. Dr. Desperito was talking about Dr. Copans. This is Dan Copans. This is Otis Brawley, head of the American Cancer Society. This is Dr. Susan Love, whom we love. And everybody lined up on different sides of this controversy. And I think the problem here is that what should have been an intellectual conversation about how we use our screening in the best way turned into an argument that gave mixed messages to women about what they should and shouldn't be doing. And that's not right. I think we did the American public a disservice with all that conversation. But at the end of it, the American Cancer Society, the American College of Radiology, the Society for Breast Imaging, the American Association for Breast Surgery, all stood by the conventional guidelines that they had been using before that new report came out, annual over 40, period. So I'm all over that. Now, Dr. Desperito gave an extremely eloquent description about breast density. And again, mammography is not a perfect tool under any circumstances, and it's less perfect in women who have dense breasts. And that's the situation, especially if women are high risk and also have dense breasts, where in a practical way, it's hard to say to someone, just rely on mammography. That's the situation where adjunctive imaging can really provide some additional information. And Dr. Desperito kind of alluded to this in some of the slides that flashed by very quickly. This is a study that was done by the American College of Radiology looking at the benefit of screening ultrasound in high-risk women with dense breasts. And they certainly demonstrated that adding ultrasound picks up additional cancers. There are false positives too. There are women who wind up triggering follow-ups and biopsies as well, but ultrasound does add something. And as anybody who knows who's had a breast ultrasound, it's an easy test, it's comfortable, there's no compression, and there's no radiation involved either. MRI has now been extensively studied in its contribution to breast cancer screening for high-risk women. And this is one of the studies that's now getting a little old, 2007, that I like to refer to, looking at women who have already had one cancer diagnosed in one breast and screening the other breast. And what this showed is that even when a mammogram was completely negative in the other breast in that context, the MRI was capable of finding an additional 3% of cancers. And that's a real number and a real benefit that we can say to people when MRI is utilized. However, MRI's got its problems. It's a not pleasant thing to do. Anybody's had a breast MRI, 45 minutes about banging and the clanging in the tunnel and all that jazz. You have to use an injection of contrast called gadolinium. Allergies are very rare, but not unheard of. And you've got to use that every time you do a breast MRI. Some people can't tolerate the exam because of claustrophobia or because they have pacemakers or other implanted devices that are not compatible. MRI doesn't, by the way, doesn't accommodate every body type either. It's expensive, a couple of grand a pop. And if your insurance company will pay for it, that's great. And if not, that's a problem. And lastly, especially in younger women, because MRI has some hormonal dependence, there are lots of false positives. I promise, I just saw a woman in my office, last patient I saw before I came here this evening. She's high risk, she has atypical hyperplasia, she's got a family history, and she had a screening MRI that just triggered bilateral MRI-guided biopsies, not to mention the second-look ultrasounds and so on. It's an awful lot to do, so it's important, once again, to deploy this important resource to the patients who will benefit the most from it. So for now, for screening, it's really reserved for really high-risk women, about a 25% lifetime risk, and certainly anybody with a BRCA mutation qualifies for annual MR. The use of MRI screening in women who are long-term breast cancer survivors is very unclear. Now, once again, surveillance is important. Early detection matters. There is no question that survival is affected tremendously by the stage and extent at which a breast cancer is detected. So surveillance is a key weapon for women who are high risk for breast cancer. At the other end of the strategy spectrum is prophylactic surgery. It's a very big deal for someone to have both of their breasts removed. The information I'm going to show you is old now, but it's probably the biggest series of prophylactic mastectomies. This looks at women who were treated in that way from 1960 to 1993. And what this series from the Mayo Clinic showed is that women who had moderate risk for breast cancer and did prophylactic surgery had about a 90% reduction in their risk of disease, and this was even higher, 94% in women who were high risk for breast cancer. So clearly, prophylactic surgery gives you the greatest protection, but there's a price that's paid. And today, in practice, bilateral prophylactic mastectomy surgery is essentially reserved for women at the highest risk for cancer, and that's BRCA carriers. 50 to 85% lifetime risk would seem to justify the intervention. Now, as it turns out, women who have these BRCA mutations are also at increased risk for ovarian cancer. And ovarian cancer, unlike breast cancer, we don't have any early detection methods that are effective. So these women are generally counseled to have their ovaries surgically removed once they are mature and have completed their families. Turns out, and no one here is surprised because of everything we've heard about estrogen so far this evening, turns out that women who have their ovaries removed and induce a very premature menopause, that strategy in and of itself, that intervention, reduces their risk for breast cancer as well. And the earlier that the menopause occurs, the more of a reduction in breast cancer risk that they get from this surgical intervention. So we talked about surveillance at one end. We talked about prophylactic surgery. There's actually a strategy that sits in the middle, and that's the use of medication to try to reduce the risk for breast cancer in high-risk women. We call this chemoprevention. And many people are aware that in the late 1990s, a trial was done in America looking at the use of the drug called tamoxifen in reducing the risk for breast cancer in high-risk women. And it certainly showed that tamoxifen was highly effective in reducing the risk for hormone-sensitive breast cancer in high-risk women. The reduction in risk was at least 50% in women who took the drug for 5 years. This was effective for women who came to the table with all kinds of risk, whether from family history or from atypical hyperplasias, and at all levels of risk they were benefited. But tamoxifen is a drug, and the side effects and complications associated with it are celebrated. We all know there is an increased risk for uterine cancer seen primarily in women over 50, but also there's an increase in the risk for blood clots, all kinds of blood clot-related phenomena. People who have issues with blood clots should not ever take tamoxifen. So then we went on to the next thing. What's a better drug? Is there a better drug or a different drug that might be effective? And the next trial, called the STAR trial, looked at a drug called raloxifene, brand name is Evista, which was already available for use for osteoporosis, chemically very similar to tamoxifen. So this trial randomized women to actually receive either tamoxifen or raloxifene to compare the two drugs. Big caveat here, raloxifene or Evista is only available for postmenopausal women. So in this study of high-risk women, they found that the two drugs had very similar benefit in reducing the risk for breast cancer. But the big difference in side effects, otherwise side effects equal, raloxifene does not increase the risk for uterine cancer, which can be a huge benefit in women who have not had hysterectomies. Now, this topic has evolved even further, and in 2011, a study was published looking at a different kind of hormonal agent called exemestane, which is one of the aromatase inhibitors, also used as treatment for breast cancer, again in postmenopausal women, chemically completely different type of drug from tamoxifen and raloxifene, different side effect profile completely, and this drug too is effective in prevention of breast cancer in high-risk groups. So there's a bigger menu now of the potential use of drugs for chemoprevention. In premenopausal women, still only one, it's tamoxifen. In postmenopausal women, the menu is tamoxifen, raloxifene, or exemestane. Now, tamoxifen and raloxifene are both good for your bones. But remember, tamoxifen increases the risk for uterine cancer while raloxifene doesn't. So women who have not had hysterectomies will probably prefer the raloxifene by cutting out an important side effect. But because the exemestane actually increases osteoporosis, as part of the evaluation process for deciding which drug a woman would be best served by, bone health is important. Someone who's got an issue with osteoporosis already would lean to the raloxifene, while someone who's got great bone health might go with the exemestane because it has a different side effect profile. And certainly, we look forward to the future when other agents are going to be investigated for breast cancer prevention. And by the way, not just drugs, not just pharmaceuticals, but maybe other naturally occurring products that have less side effects. The goal is to give the best prevention with the fewest side effects. Dr. Smith covered this a little bit. It bears repeating. There are different lifestyle factors that are also associated with breast cancer risk, and these are modifiable. So it's an opportunity to do something. Smoking is linked to a lot of cancer. Breast is one of them. Nobody should smoke. The statistics about alcohol, when you drink at the level of 7 drinks per week, like every single day, that's associated with a 20% increase in the risk for breast cancer. So we probably shouldn't drink alcohol every day either. Obesity is associated with an increased risk for postmenopausal breast cancer. Once again, this represents a modifiable risk factor. You can't fix your genes. You can fix your weight, probably. So, as the American Cancer Society tells us, maintaining an appropriate weight, following those recommended guidelines for a healthy diet that Dr. Smith talked about, engaging in moderate exercise, and avoiding risk-taking behaviors, smoking, alcohol, additional hormones, etc. These are all strategies that are available to everybody. They don't need a doctor to write a prescription. They don't require any other invasive intervention. We can all do these things every single day, and they may have a significant impact on breast cancer incidence. Now, eventually, where we'd like to go with this is to develop a system where we can help an individual woman have a clear, quantified understanding of her own potential risk to develop breast cancer. We'd like to figure out how we can look at someone's breast and understand what their imminent risk of breast cancer really looks like. And this is going to need something. We're going to have to find some kind of a biomarker that's present in the blood or in the tissue or in the urine that will help us understand who's really at risk and also help us track how well our risk reduction methodologies work by showing that it's reversed or decreased in the setting of appropriate intervention. And we'd like to get to the point where we are picking up women kind of in these places over here and intervening so we don't get to that place, that invasive, ugly-looking spiculated breast cancer that Dr. Desperito showed. That's the goal. That's the target. And I don't think that this is terribly far off in the future either. But after the long discussion about how to tell if you're at risk and how to quantify your risk and what are your options for modifying your risk, I think it also boils down to the understanding that risk assessment and discussion of options is a dialogue between a physician and a patient, and it's not a monologue. And the patient also brings something to that conversation. So I like to say that understanding risk and making decisions about risk, it's a lot like crossing the street in New York City, okay? When you cross the street in New York City, the traffic lights are pretty irrelevant. So what we all do is we stand at the corner. I'm a New Yorker, born and bred. We all know this. You stand at the corner. So what do? You look and you say, is there a car coming? Is there a threat coming? Is there a car coming? And then you say, how fast is that car coming? How imminent is that threat to me right this minute? And then I think, well, wait a minute. Am I carrying baggage with me? What else is going on here today that makes me slow, that makes me not be able to avoid that risk, or nimble today where I can avoid the risk? And lastly, and this is the thing that's not quantifiable, I stand at the corner and I think, how lucky do I feel today? So for all of us, when we think about that breast cancer risk assessment, we have to think about our own preferences and our own values, what the risk looks like, how imminent is it, how big a threat it is, what we can do to avoid it, and then come to the right conclusion about the strategies to use in order to modify that risk and hopefully wind up at that place of good prognosis and good outcomes. So thank you very, very much for being here with us tonight. We want to thank Komen for co-sponsoring. I want to thank my colleagues at Columbia University Medical Center for participating with us this evening. Please fill out evaluations. We want to know what you thought of tonight's program so it can help us do great programs in the future. Dr. Joseph wishes she was here, and she sends all of her regards to everybody, and we will have some time for questions and answers. Thank you very much.